Good afternoon, respected senior faculties, my colleagues and residents. On behalf of Surgery Unit 2, would like to continue the same discussion involving the almost similar discussion involving the same system, vascular, uh, but from a surgical perspective. So we are going to present a very interesting and challenging case, vascular, but involvement of the GI system. Our junior resident, Dr. Saksham Gagal and Dr. Lipton, senior resident, will be presenting the case. I request Dr. Saksham to please start the case.
Good afternoon, everyone. I would be quickly taking you all through the case and then following how did we manage it. So our patient is a 22-year-old male. He presented to us with bleeding per rectum since 2 years of age with right lower limb deformity. The bleeding per rectum was unevaluated till early adulthood. It was insidious in onset but was gradually progressive and about 30 to 40 ml in quantity with every defecation. It was bright red mixed with stools but was not associated with passage of clots. It was associated with constipation. There was no history of melena, hematomesis or easy bruisability. So he was diagnosed with hemorrhoids when he visited outside hospitals for a decade and was treated in the line of hemorrhoids. So he was managed with iron supplements, banding 3 sessions and sclerotherapy was tried 5 sessions. But there was minimum symptom relief and he required total 16 blood transfusions in the previous decade, which he required every 3 to 4 months. So at 2 years of age, he also developed right lower limb hypertrophy. He was unable to straighten his limb, for which splinting was done, and it was affecting its quality of life significantly. On orthopedic review, he was advised long knee brace and was taking regular physical rehabilitation. In December 2021, he developed right lower limb swelling and pain, was diagnosed with DVT. So IVC filter was placed in view of ongoing bleeding, and so no anticoagulants were used for him. There were no other comorbidities. Personal history was unremarkable except from the occasional constipation. On general examination, he was thin built, pallor was present and koilonychia was present, all of which suggested chronic blood loss. On local examination, the patient had right lower limb disparity with flexion deformity due to right hamstring contracture, and there were prominent dilated veins in the right popliteal fossa and right foot. There was swelling in the right gluteal region, and there was a tuft of hair present in the sacral region. So here on, we were started thinking that this could be something syndromic. On systemic examination, it was non-contributory. On perrectal examination, there was circumferential mucosal irregularity starting 2 to 3 centimeters from the anal verge. On proctoscopy, the mucosa was congested and dark in color. On routine investigations, his hemoglobin was 7.1, which was low, and the D-dimer was slightly raised. So Doppler of lower limb established thrombosis in deep venous system, also in the superficial venous system, and there was multiple dilated vessels which were suggestive of venous malformation. Ultrasound abdomen was done, which showed no evidence of portal hypertension. Colonoscopy revealed grossly enlarged venous malformations that occupied entire rectum circumferentially and also involved the distal sigmoid colon. The MRI lower limb was done, which showed low flow vascular malformation. It involved the right gluteal region and extended up to the plantar compartment of the foot. There was deep vein thrombosis also established. Now I would like my radiology colleague to discuss the MRI and the X-ray findings.
So good afternoon, everyone. So these are the X-rays. This is the pelvic X-ray. There is mild right pelvic tilt, and there are few tiny round radiopaque spots in the right pelvic region, and there is increased soft tissue opacity in the right half of pelvis and the proximal thigh. So the MRI pelvis, these are the T2-weighted non-fat set images on all the 3 planes. We can see that there is a circumferential mural thickening of the rectum, and also it is involving the sigmoid colon as well. And there are small prominent flow voids in the mesorectal fat. The disease is contained within the mesorectal fascia. And these are the post-contrast images. We can see that the thickening enhances on the post-contrast images, and there are very much prominent vessels in the mesorectal fat. Now these are the images, T2-weighted non-fat images, focusing on the right gluteal region. So we can see that there is an ill-defined infiltrative T2 heterogeneously hyperintense lesion involving the muscles of the right gluteal region and also the involving the posterior aspect of the right thigh. And the lesion contains multiple small signal voids. So these are likely to be representative of phleboliths that we were seeing on the X-ray. And on the post-contrast imaging, we can see that the malformation of the right gluteal region enhances, and the deep vein we can see it is normal. So the rectal vascular malformation and the gluteal vascular malformation are the two different entities. So this was the malformation was involving the rectum and sigmoid colon, and also was in the right gluteal region and the posterior compartment of right thigh.
Thank you, Dr. Rajneesh. So putting it all together, the patient had right lower limb hypertrophy, has varicose veins, and has GI involvement predominantly in the rectum. So it fits into the syndromic manifestations found in the Klippel-Trenaunay syndrome. So we made a diagnosis on the clinico-radiological basis that the patient has low flow venous malformation and it involves the diffuse rectum and the sigmoid colon. So what are the treatment options that we can proceed? So medical management was unsuccessful in this patient. He was being treated for medically for past 10 years. Interventional therapies are not suitable, which would be discussed by my colleague later in the literature of review. So we opted for surgical resection for this patient. So the patient has diffuse and extensive disease. He is young and there is no definite arterial feeder as seen in the MRI. So the patient needs a permanent solution which has low recurrence so he could lead a better quality of life. So we opted for a surgical option so we could radically remove the disease in one time, and so the patient remains symptom-free lifetime. But the challenges for the surgery are not as usual for the rectal cancer surgery. So the patient has dilated thin-walled malformed pelvic veins which are involving the rectum, the mesorectum, and the pelvic walls. So even one touch can lead to problematic bleeding. The patient chronic history has rectum is thickened and stiff. There is a risk of permanent stoma with difficult pelvic dissection and risk of urinary and sexual dysfunction. So classically, there are two surgical options proposed. One is the low anterior resection, that is the LAR, and the abdominoperineal resection, that is the APR. The LAR does not remove the complete disease and is associated with recurrence because we leave the disease behind lower down. But APR removes the disease, but there is a formation of stoma and risk of urogenital dysfunction. So neither of them felt right as is. So we need to find some path midway. So we'll be discussing the embryological basis of the mesorectum. So here we can see that the rectum is, and the surrounding structure, the soft tissue is the mesorectum, and there is a natural envelope covering the mesorectum. So all the vascular channels and the lymphatics, they develop within this mesorectum. So the mesodermal origin of the venous channels, if the venous malformation occurs, all the channels should be within the mesorectum and been confined by the mesorectal fascia. Here in our patient, because he had Klippel-Trenaunay syndrome, there were dilated channels along the lateral pelvic wall also. So Dr. Heald, he proposed the holy plane of Heald, which is, he proposed as an avascular plane for dissection, and he proposed it for a radical resection of rectal cancer surgery. So this was the plane he told to go forward with the resection. So in our case, we hypothesized that the AVM arises from the mesodermal tissue. So we proceeded ahead to go with the total mesorectal excision in toto. So we could remove all the disease intact in one packet and remove and give the patient a better quality of life. So we go forward removing the mesorectum and then go between the internal and the external sphincter to go intercentric dissection. So our plan was mesorectal excision with the coloanal anastomosis. The patient was positioned in the low lithotomy position for good pelvic access. Standard laparoscopic ports were used. So here's the video. So on insertion of the scope, we can see dilated pelvic vessels involving the entire rectum, the anterior wall, the lateral pelvic wall. So the dissection was continued. This is the sacral promontory. We started the dissection here. You can see the planes loose areolar tissue opening up with the help of pneumoinsufflation. The first step would be to ligate the internal inferior mesenteric artery so that it reduces the blood supply and we could control even severe bleeding. Here we can see there are dilated vascular channels. This is the mesorectum. This is the posterior wall of the rectum, and this is the posterior wall the sacrum and the dilated channels above it. So this plane, we can see it opens up slowly and there is minimal to low bleeding. Towards here, we can also see these are the dilated ectatic bluish hue, which is suggestive of the dilated pelvic vein. So we have to remain in this plane, which is avascular. Even if slight millimeter of dissection, we can go. This can cause torrential bleeding. So this is the posteriorly holy plane of heel. So now the dissection. This is the left lateral dissection. So here also this plane should be maintained. So anteriorly also you can see the important structures such as vas deferens. So slowly these planes have to. So here this rectum in mesorectum, it is completely studded with the venous malformation. These might look very small, but once you open them, they will destroy our whole surgical field, will lead to destruction of the planes. So our ultimate motive is to find go down till the levator to find the intersphincteric space so that we can preserve the sphincters finally. So here also the mesorectum is completely studded by the venous malformation. These are the dilated veins laterally. So our complete rectal mobilization is now complete. Now we will reach the levator. This is the intersphincteric space. Now the perineal surgeon, he starts to open up the space from the pelvis side. Now the rectum is divided. The specimen is being removed. So the proximal good margin here complete should be free of the disease. Now it is being divided. And the mesorectum is completely removed. So the coloanal hand-swing anastomosis is now being performed. So this is the final specimen of the resection. This is the anterior wall which was studied with the malformation, and this is the mesorectum anteriorly. Posteriorly, this is the complete mesorectum which we can identify with the shiny surface. On cut specimen, you can see dilated thin walls, and this was the proximal end of the vein which suggests of healthy mucosa. This was the dilated thin rectal. Estimated intraoperative blood loss was 300 ml. The patient was transfused 1 blood postoperatively. Further, course was uneventful and was discharged on post-op day 5. 6 months after, ileostomy was reversal upon complete healing of the anastomosis. So I would like our pathology colleague to discuss the histopathology of the patient.
So this is a segment of colon, which on gross examination, you can see that mucosa is dull and the cut surface of all the layers shows congestion. This is a microscopy which shows that mostly there are the multiple dilated thin walled blood vessels, predominantly in the submucosa, although there were some dilated blood vessels in the mucosa also, and all of the layers were equally involved. This is a high power. These are which show the same thing, the multiple thin walled dilated blood vessels, tortuous, and they are filled with blood and show congestion, and one of the blood vessels which is showing the thrombus here. So overall features were compatible with the clinical diagnosis of vascular malformation. So these are mainly, this is some of muscles. So this was vein and mostly were venules. When they get dilated, we couldn't appreciate much of the muscle layer, but it was there. Like here, this is a smooth muscle.
Thank you, Dr. Shalini. So we followed the patient up for 4 years because it is important here, because we should ensure that the patient remains symptom-free after 4 years. So there were no further bleeding episodes. His hemoglobin at 2-year follow-up was 10.2, which increased to 13.6 at 4-year follow-up. And there were further no transfusion requirement for this patient. His stool frequency was normal and the continence was preserved, and there was no bladder or sexual dysfunction. So following this, after discussion of the outcome, I would like to invite Dr. Lipton sir to give a review.
So thank you, Dr. Saksham. Since it is a rare disease, so I have more of case series and case reports to discuss. So I'll be discussing a review of literature here. So what exactly is a vascular malformation? So broadly, we can divide into two categories, fast flow lesions and slow flow lesions. In fast flow, we have arteriovenous malformation and AV fistulas, while on the other hand, we have venous, lymphatic, and capillary malformations. If we look at the difference between AVM and venous malformation, so generally we embolize the AVMs and we perform sclerotherapy in case of venous malformations. But in case of diffuse and extensive disease, as we had, we should go for surgical approach. So what is rectal venous malformation? A rectal venous malformation is a congenital abnormal dilated venous channel within the rectum and or mesorectum. So MRI is superior to CT for venous malformation characterization and follow-up, especially for defining the upper extent and the adjacent organ involvement. Now, a little bit about Klippel-Trenaunay syndrome. So it is characterized by a triad, which is a port wine stain, venous malformation, varicosities, and bone or soft tissue hypertrophy. So it is a rare disease, approximately 1 in 20,000, and presentation is early childhood. So where does this KTS, which is Klippel-Trenaunay syndrome, fits into this ISSVA classification? So it is basically a slow flow vascular malformation. In up to 20 to 30% of the Klippel-Trenaunay patients, there is GI involvement, and out of that, rectum is the most common site which is involved. Embryologically, the rectum develops within the mesorectum. So normally what happens, these primitive venous plexuses usually regress, but in case of Klippel-Trenaunay, the regression fails, which leads to persistent embryonic veins within the mesorectum, which progressively enlarge with the age. So treatment options, so these are the treatment options available. So sclerotherapy, it needs multiple sessions, recurrence is the issue, and associated pain and infection is there. Radiotherapy, uncommonly done, again recurrence is the issue. And if we look at the endoscopic approach, so this is feasible for the focal, superficial, submucosal diseases, and it fails in transmural diseases. Pharmacotherapy, certain drugs are postulated in the literature. So sirolimus, alpelisib, these are actually used in those where it is not amenable for interventional procedures. And endovascular embolization, again, it is not useful in diffuse diseases, chance of collateral recruitment and risk of infarction is there. So all these conservative approaches, they are not always helpful. So treating the mucosa does not necessarily treat the malformation. So rectal VM, venous malformation, is frequently transmural, and recurrence is the issue here. And these approaches are usually kept for poor surgical candidates. So diffuse disease like our patient may ultimately require the surgical resection. So this is a case report where two patients who had a massive rectosigmoid venous malformation involving the whole circumference. They underwent around 13 to 15 hybrid sclerotherapy sessions each. So one patient had decreased bleeding, but it did not stop completely. And second patient died from the recurrent bleeding. Another case report where selective embolization was done. So at 1 year of follow-up, the patient developed a small ischemic ulcer at the rectosigmoid junction. The bleeding although became less and less severe, but he still required parenteral iron therapy. This is one of the large case series involving 17 cases. So I have kept this series here because one patient who was not able to be operated due to extremely high perioperative risk in the form of tremendous size of hemangioma, altered structure, and severe thrombocytopenia. He received 20 gyri of radiotherapy, and at follow-up of 8 years, there was decreased rectal bleeding, but again, bleeding did not completely resolve. So this is a meta-analysis to look for the effectiveness of sirolimus. So there was clinical improvement in up to 72% of the cases, patients. There was reduction in lesion of this lesion size. Patients had adverse drug effects. So it was concluded that drugs can be disease modifying rather than curative. Now coming to the surgical options. So historically, APR was the mainstay treatment for these. So it basically, it is the complete removal of the disease rectum. So in the image also we can see, so this whole thing is removed, including the, it removes the bleeding lesion, potentially minimize the recurrence, and technically looks definitive. But is it too much for such a young patient? So for a benign disease, the cure should not become a lifelong disability, as in permanent colostomy, loss of anal sphincter, and major impact on body image and quality of life, associated perennial morbidities, and potential urinary and sexual dysfunction. So if not APR, will low anterior resection suffice? So low anterior resection, we can see the dotted line. So it is preserving the sphincter complex and removing rest of the involved segment. So again, of course, there is no permanent stoma in this surgery, and sphincter can be preserved, but the remnant venous malformation can be there in the distal rectum. And again, there will be high recurrence. So this is a case series of involving 3 patients, where patients, one had to undergo APR because of, again, extensive disease, and 2 underwent mucosal proctectomy with coloanal anastomosis. This is quite similar to our patient. So 25-year male, again, this patient, and in a case of known case of Klippel-Trenaunay syndrome, he underwent laparoscopic ultra-low anterior resection with coloanal anastomosis with the diverting loop ileostomy. So with all these surgeries and all these ideas, we come up with the concept of total mesorectal excision for rectal vascular disease. So there is something holy plane of Heald which lies between the mesorectal fascia and parietal pelvic fascia. We can see in the image. So where did this concept came from? So we got this concept from the radical rectal cancer surgeries, where this concept is mandatory to follow. So TME, that is total mesorectal excision, removes the entire embryological vascular compartment instead of only bleeding mucosa. So the principle behind this total mesorectal excision is that most of these venous malformations arise from the mesodermal tissue. We can see in the image, and it is all are confined within the mesorectum. So the dissection in this plane, we do not encounter any major vessels, and it avoids the trauma to venous malformations as well. So practically speaking, it is a avascular plane of dissection. This is a case report published by our department. This was a 38-year-old lady who underwent laparoscopic total mesorectal excision with intrasphincteric resection and coloanal anastomosis. So after follow-up of 18 months, there was no recurrence of bleeding, and ileostomy was subsequently closed. So this total mesorectal excision is a concept which is appreciated by and followed by other surgeons as well. So this surgeon performed transanal total mesorectal excision. So he approached via transanally because the lesion was quite close to the dentate line, up to 5 centimeter from anal verge. So he did TATME with stapled coloanal anastomosis, and again the results were satisfactorily. So the advantage of this concept, total mesorectal excision with coloanal anastomosis, it avoids all the issues we had with APR. So I conclude with this, that total mesorectal excision with coloanal anastomosis is a robust option for rectal venous malformation. Now I would call Professor Himang Bhattacharyya sir for further discussion.
Good afternoon, sir. So, thank you, Lipton and Susan, for bringing up the case quite lucidly. So, when we got the case, sir, he is a young male, has multiple episodes of rectal bleeding. And when you look at his MRI, it was very scary. Whole rectum mesorectal tissue is studded with blood vessels. And there are blood vessels on the lateral pelvic wall as well. So, obviously, to remove these lesions is the ultimate option, but that is associated with very high risk if we follow the conventional ways of managing a case. By the time we got this case, we already had another case who had rectal AVM per se, but without KT syndrome. So in that case also, we hypothesize that everything is embryological. The whole vessels comes along the mesorectal fascia, and if we maintain that fascia intact, then probably we could avoid bleeding. But here in the second case, also the KT syndrome, which make it complicated because of the lateral pelvic wall vessels. So it was almost like walking on a string, because both the sides there are blood vessels, but we have to find out that embryological holy plane, which can give a very vascular. So based on that concept, which is borrowed from malignancy, we endeavored this case, and successfully we could remove the tumor without and find out the sphincter very adequately and do a restorative coloanal anastomosis. So outcome was very satisfactory, and till now he has completed almost 4 years. He has no subsequent history of blood transfusion, as well as there is no need of, and his sexual and urological functions are very well preserved. So with this, we actually concluded that even a benign disease like this can offer a radical surgery of total mesorectal excisions to obtain adequate functional outcome as well. So till now, we have operated 5 different cases of rectal venous malformation with this concept of total mesorectal excision, of which the second case was associated with Klippel-Trenaunay syndromes. And all those 5 patients are still working good and without any recurrence and requirement of subsequent blood transfusions. With this, I conclude our presentation, and I invite comments and suggestions. Thank you. Yes, all the patients had a low flow vascular malformations. So all of them underwent complete excision of the malformation part till the intersphincteric space, then a coloanal anastomosis, so that their sphincter function is protected. Ma'am, you can come over here.
So hemangioma will be a distinct lesion. Like we can see ki here it was fully involving all the layers, and it was everywhere. So hemangioma will be seen in a particular section or particular. So it will have localized. Yeah, yes, sir.
So fortunately, our colleague, radiologist colleague, always say this is a low flow vascular malformation. You can go ahead with surgery. So, but I think if the few other cases where arterial supply is still prominent, probably their intervention radiologist attempt can be obtained. But here it was mainly of vascular origin, of venous origin. Thank you. Thank you. Sir. Thank you. Thank you, everyone.